Oh, yeah.
So, I mean, it wasn't hugely positive. There was a trend towards positivity, but it demonstrated two things. One is that, contrary to the fear earlier, it could be used in severe infections also, did not cause any harm. And
Yep.
second, since the follow-up was only about 3 months or something like that, then maybe we didn't see the quantum of benefit which might have seen earlier with a longer trial.
Yeah.
So, don't know, but interesting.
I'll show the other study that they presented, the Chief HF, that I've enjoyed working with him over the last few years. He's a good investigator.
He's a very intense person.
I mostly know him over Zoom, so,
Dr. Abraham has joined. Hi, Bill.
Hi, how are you?
Good. We met in Nice 3 weeks ago.
Yes, it was
And
very
here we
nice.
are again. So, Bill, you don't have slides, I understand. So,
Actually, I will share a few slides.
okay.
Yeah, focused on it. It looks like drugs and devices. What's new? So I'll say a little bit about some devices.
So, in that case, Dr. Sani, I think we stick to the original plan.
Sure.
Dr. Cannon, Dr. Abraham, and then you come in and.
Yes.
Yeah. Sandeep sir, we are live. So we are live.
Right. So can we start with the permission?
Let's start.
Right, sir. Right, sir. The screen is visible, I believe.
Yes.
Right. A very warm greetings and welcome to this, Best of AHA 2021 to all respected doctors, our distinguished expert panel in the cardiology. My dear colleagues, ladies and gentlemen, at the outset, Ms. Sandeep Mitra, on behalf of Curious Mankind Specialty, take this immense pleasure and the opportunity in extending a warm welcome to this academic event. And this is in continuations of the academics and the cutting edge science, which you have been witnessing over the last couple of months among the various international congress of the global repute. Therefore, we are pleased to bring to you the best of American Heart Association's meeting we just got over yesterday. Dear Doctor, Curious Mankind Specialty, as we know that it's a super specialty cardiac care team to serve the millions of the cardiac care patients across the India with the quality and affordable healthcare products and the services. One of our integral strategic intent and partnerships is being to remain the forefront in the knowledge sharing, and towards that we made a exclusive strategic partnerships with some of the distinguished and reputed national and international congresses, and also to remain in forefront in the patient educations and the awareness through various digital solutions like One Life and the Prana Life Force. Dear Doctor, thank you very much for accepting our invitations and making this event possible. And it gives us immense pleasures and the honor to introduce and invite Professor Dr. V.K. Chopra, who is our honorable distinguished experts in the cardiology, and Professor Dr. Chopra, who is going to chair this particular sessions. As we know, the Professor Dr. V.K. Chopra, who is the Senior Director at the Max Super Specialty Hospital, New Delhi. He is the founder, President of the Heart Failure Associations of India. Thank you very much, sir, for accepting our invitations. With this brief note, may I request Professor Chopra to kindly start the sessions with your opening remarks and introducing the speaker of the evening. Over to Professor Chopra. Thank you, sir.
Thank you, Sandeep, for a very kind introduction. And a very warm welcome to everybody for this evening's webinar. This is as hot off the press as it can get because this session was over just a few hours ago. So we are very pleased today to have a very distinguished panel of experts to take us through the highlights of this important conference and tell us what are the lessons that we learned. Let me introduce very briefly Dr. Chris Cannon, who's works in Brigham and Women's Hospital. He's a professor of medicine at Harvard Medical School. Dr. William Abraham, who's a professor of medicine, physiology, and cell biology. in College of Medicine and a distinguished professor, Division of Cardiovascular Medicine at the Ohio State University, and my former colleague and a good friend, Dr. J.P. Sahni, who's chairman of the Department of Cardiology at Sir Gangaram Hospital, New Delhi. This seems to have become the new format now, as we have all seen after the COVID era. On one hand, while we miss meeting each other very, very significantly, yet these meetings provide us with a very wide reach to educate or to get in touch with a very large number of our colleagues. And therefore, at least there is some benefit. Today's session will be divided in three portions. Dr. Cannon will initially take us through the update on SGLT2 inhibitors dominantly, because as we know that SGLT2 inhibitors, as Dr. Cannon was saying, they are everywhere now. And in the last few months or couple of years, probably these drugs have generated more publications than any other aspect in field of cardiology. And this will be followed by Dr. Abraham taking us through new developments in drugs and devices. And finally, Dr. Sahni will tell us about the assorted other breaking trials. Each of these sessions will be for 15 minutes. And after that, we'll have a question and answer session. And I would request the audience to keep on sending their questions. We'll be very happy. We have a very, very knowledgeable panel, and they'll be glad to take your questions. So with that little introduction, it's my great pleasure to invite Dr. Cannon to start off his presentation. Dr. Cannon, please.
Well, thank you all very much. It's a delight to join. And I'll cover some of the areas of SGLT2 inhibition and begin with a bit of review and then some of the more recent studies that have been presented at AHA. I think one of the aspects that we continue to learn about, and I can't really speak to all the details of this slide, that there are multiple mechanisms of this class of drugs. It does have negative caloric balance, which is good in diabetes, obviously. But on the right, the tubuloglomerular feedback I picture as one of the major effects in the kidney directly, and then having a big impact on heart failure as well. These are, the 4 ASCVD trials. There are now 11 large trials and several moderate-sized trials. And the pattern has been generally benefit, and I've color-coded green the significant benefits that have been seen. The first trial was significant on all 3 endpoints of MACE, cardiovascular death, and heart failure. And then, as we'll see, also prevention of renal disease. And then others showed strong trends, but not necessarily significant, but generally across these 3 endpoints, benefit seen of the SGLT2 inhibitors. About a year ago, we did a meta-analysis, and of 5 of the trials, this pattern has held up. And so I've included these where MACE, it's a modest reduction, about 10% overall that's been seen across the various trials in ASCVD. And so not a huge effect, but some benefit. Cardiovascular death was a 15% benefit overall, some heterogeneity where the biggest effect seen in the first trial, EMPA-REG, but others showing trends as well, but 15% reduction. And then for time to heart failure, those same 5 trials on the top, and I'll show 1 or 2 slides of the others, that it's a 30% reduction in the risk of heart failure. And this has been seen almost identically in every single trial. This is a meta-analysis of the trials looking at the renal endpoint. And again, consistency, more like about a 40% reduction in progression of renal disease. And that was followed up by partway through that series of 4, I guess, the dedicated trials, and this was the first of the renal trials of credence, that on harder endpoints, including just end-stage kidney disease, that there's a significant reduction in events with this class of drugs. Then the earth got shaken again when DAPA-HF presented the data in patients without diabetes. And so all the prior work had been done in patients with diabetes, but these benefits, as shown towards the bottom here, were equally present in those without diabetes. So prevention of cardiovascular death or heart failure in patients with heart failure and reduced ejection fraction here. But several other studies have also found this benefit on heart failure and renal disease, especially in patients without diabetes. One of the more recent developments has been the use of these closer to an index hospitalization for heart failure. And so the Soloist worsening heart failure trial focused right at the time of hospital discharge and within a few days, where we're trying to get the 4 different agents on board of, neprilysin, beta blocker, MRA, and then it added the SGLT2 inhibitor. And so what was seen was a huge early benefit of adding an SGLT2 inhibitor, in this case, sotagliflozin, where the number needed to treat was 4 patients to prevent a patient from having a cardiovascular death or hospitalization or urgent heart failure visit within 1 year. So it's just amazing, really, how powerful these drugs are. And this is the highest risk setting. And so it's in part really spurred emphasis on getting these therapies, especially SGLT2 inhibition, started early because it has such a rapid effect. So from AHA, related to this, there were several trials. I'll focus on 2. The CHIEF-HF study looked at quality of life in symptomatic patients with heart failure and focused on symptoms, I think an interesting perspective. And then the Impulse trial looked at acutely hospitalized patients, so even a day or 2 earlier than was done in the Soloist worsening heart failure, at least on average. So beginning with the Impulse trial, this was a moderate sized trial, about 260 patients in each group, and had both patients with reduced ejection fraction, about 2/3, and preserved ejection fraction. Many people had chronic heart failure overall. And so what was seen, they had sort of an interesting endpoint that included a symptom questionnaire and found that overall there was significantly greater clinical benefit. This is a small trial, so looking at clinical endpoints, there weren't enough of them. But driven by the symptom questionnaire, they saw an overall clinical benefit when starting this very early after a hospitalization, or at the end of a hospitalization for heart failure. And they did report out and actually saw this benefit on the overall compensation or status, and it again starts very early. And so part of the lesson has been between this trial and Soloist is that these are a class of drugs that we don't want to wait months to get started. And so they concluded, and this is a slide from the presentation posted up on Twitter, which is how we get a lot of our information, that they saw a significant clinical benefit, fewer deaths and heart failure events, improved quality of life, weight reduction, as we know, and really no safety concerns in that acute setting, where often people have worried, would there be bad metabolic effects and create DKA and other issues. So very encouraging for that earlier use of this class of drugs in heart failure. So another presentation, John Spurtis did this, and Mikhail Kosovorod was, helping lead this, was the Chief HF study. And they talked about sort of dual goals here of obviously trying to prevent heart failure admissions, but then also trying to help the patient's status and their quality of life and functional status. And John Spurtis has dedicated his career to measuring this in different settings, and now in heart failure to see how do you make patients feel better. So this was a neat trial, and our chair did another trial also in COVID, but this is during COVID, this was done of a randomized trial with follow-up visits, but no face-to-face visits. So a completely virtual trial, which is one of the neat new developments is how do we make clinical research easier for patients to participate in? And so they did this where they did everything without patients having to come in. And so they looked at patients both with HFrEF and HFpEF, but who had elevated the Kansas City something quality of life score that it had to have evidence of limitation on there. So these were symptomatic heart failure patients so that they couldn't do all of their daily living, sort of like a class 3 type patient. And so that's an ideal group to assess whether there could be improvement in their symptoms. And so what they saw was indeed improvement. And this again happened relatively quickly. Within 2 weeks, they found improvements in their total symptom score, that patients were able to do more and feel better with the addition of, in this case, canagliflozin. And so they concluded, sorry for all the builds here, that this did improve heart failure symptoms. It was present in patients with lower normal EF. Also, they did study it and emphasize this patients without, diabetes. And so this again says that this is helping patients feel better overall. And then, in a novel way, this provides a model for how to do future clinical trials. Now, I'll share with you something that I presented at the European Association of Diabetes that links into this, where we were in this study, Virtus-CV, we added the SGLT2 inhibitor. This was in patients with ASCVD. About 20% or so had baseline heart failure. And we saw a reduction, as we saw in the thing of heart failure, hospitalizations for heart failure. And so here we were looking at something less severe. So not just an urgent hospital visit, but were there patients not started on diuretics? And so over the 5-year period, as you can see here, there was a significant reduction in patients being started on diuretics. And so this is sort of subtly hidden in the database. We didn't think to look at it until a year after the study, where this would be, similar to the symptom improvement, a way that patients are feeling better, that you don't have to start them on a loop diuretic. And so in addition to all the big major events, there are these more subtle events that you improve patients. And I've certainly seen this in my patients as well, that they feel better when starting on an SGLT2 inhibitor. And then finally, some new data presented from the sotagliflozin program that looked at the benefits of that agent, sotagliflozin, across different levels of renal dysfunction. And the key finding from this study was that in patients with renal dysfunction, SGLT2 inhibitors really don't have as much effect in the kidney on controlling hemoglobin A1C. But here you can see in the study that there was a significantly greater impact on hemoglobin A1C, even in those who had chronic kidney disease 4 or 5. I think mostly 4, so the eGFR less than 30, that upper left corner. And so highlighting the fact that the SGLT1 inhibition does contribute to its overall impact. And then this was one of several analyses that they looked at the analysis of benefit. And this is number of events, placebo in red, and you can see across the entire spectrum, fewer events in those who got sotagliflozin, regardless of your baseline eGFR. So, re-emphasizing the benefit seen, even in very low eGFRs and higher as well. So the conclusion that Dr. Brownwald published about within this past month is a nice takeaway to say that SGLT2 inhibitors are the statins of the 21st century, that everywhere we look, there's clinical benefit. And so the final slide, now we're up to 11 large trials. We've just reviewed some of the moderate sized trials that really reaffirm the guidelines that say that while we always start metformin for patients with diabetes, we then, regardless of the hemoglobin A1C, look at the clinical background for the patient. Do they have ASCVD or multiple risk factors? Do they have heart failure or chronic kidney disease? And in each of those groups, which comprises a huge percentage of our population in cardiology, that benefit has been seen, and we need to really push to try and implement these agents. So with that, I'll stop and delighted to continue in the program.
Thank you, Chris, for a wonderful summary of the current information on SGLT2 inhibitors. We'll pick your brains a little bit later after the 3 presentations are over. Bill, over to you for your presentation.
Yeah, thank you so much. Let me bring up a few slides. I did want to follow on to Chris's presentation and just make a couple of comments about SGLT2 inhibitors in patients with preserved ejection fraction heart failure. And I'm only going to show 2 slides here, which I hope that can confirm are shown on the screen. This first slide comes from the original presentation at the European Society of Cardiology meeting in August of this year of the Emperor Preserve trial, and it shows results for the primary endpoint, cardiovascular death, heart failure, hospitalization, in selected subgroups. And a question was raised following the presentation and publication of these data on the effectiveness of empagliflozin in patients with preserved ejection fraction heart failure by LV ejection fraction. And you can see here that I've highlighted what appears to be a trend of the diminishing effectiveness as the LV ejection fraction rises above 50 or 60%. So as the American Heart Association Congress just concluded, there was a subgroup analysis presented of the Emperor Preserve trial based on LV ejection fraction with a cut point of 50%. So patients were grouped into 2 subgroups, those with LV ejection fractions ranging from 41 to 49%, and those who had LV ejection fractions greater than or equal to 50%. And to make a long story short, here you can see that there was no significant interaction by LV ejection fraction on outcomes for the primary endpoint, total heart failure hospitalization, all-cause mortality, or the change from baseline in the KCCQ quality of life score, such that we can now conclude from these data that there is no difference in outcomes in the treatment of preserved ejection fraction heart failure with an SGLT2 inhibitor based on LV ejection fraction. I think these are very important findings which support the use of SGLT2 inhibitors, not only in patients with heart failure with mildly reduced or mid-range ejection fractions in that range of 41 to 49%, but also in those patients with perhaps what we might call true preserved ejection fraction heart failure or normal ejection fraction heart failure with LVEFs of 50% or greater. Now, I'm going to bring down that particular presentation, and let me bring up a presentation that I want to share with you on device therapies in heart failure. Let's see. Okay. Yeah. Okay, and so hopefully now you can see a slide set entitled Sequencing of Device-Based Therapies for Heart Failure. And I'll take you very quickly through what's happening in the device arena for the treatment of heart failure. And I'll start by showing you that there are a number of emerging device therapies for heart failure that have been approved, at least in the US, by the US FDA over the past several years, beginning in May of 2014 with the CardioMEMS heart failure system for the implementation of pulmonary artery pressure guided heart failure care, to the Remedy system for the delivery of transvenous phrenic nerve stimulation, a treatment for comorbid central sleep apnea and heart failure, to most recently, just within the past 2 years, the expanded indication for MitraClip, the approval of the Optimizer Smart System for the delivery of cardiac contractility modulation therapy, and the approval of the Veristim Neo system for the delivery of baroreflex activation therapy. And I'm going to take you through very quickly these 3 most recent devices to emerge for the treatment of heart failure, and then develop with you an algorithm for their use, acknowledging that perhaps not all of these device therapies are widely available in India. But let's focus first on functional mitral regurgitation as a target for heart failure therapy. About 40% of heart failure patients have moderate or severe mitral regurgitation. Secondary or functional MR is associated with a poor prognosis in our heart failure patients. It contributes to heart failure disease progression, symptoms, and poor clinical outcomes, be it increased ventricular loading and increased left atrial pressure. There is a trial called the COAP trial, which strongly supports the use of transvascular edge-to-edge mitral valve repair. The device for accomplishing this is shown on this slide. It is, you'll recognize, the MitraClip device. And again, as studied in the COAP trial, it resulted in a highly significant 47% reduction in recurrent or cumulative heart failure hospitalization, the primary endpoint of the COAP trial. But it not only reduced the risk of recurrent heart failure hospitalization, MitraClip also improved all of the 10 hierarchically tested and powered secondary endpoints in the COAP trial, from significant reductions in MR grade to outright reductions in all-cause mortality at 12 and at 24 months, to improvements in other composite-based clinical outcomes endpoints, and importantly, to highly meaningful improvements in quality of life, functional status, and exercise capacity. The use of MitraClip for the treatment of secondary MR in heart failure patients was highly successful. For example, the between group difference in the KCCQ overall score was about 12.5 points, and the improvement or proportion of patients improving their New York Heart Association functional class ranking to either 1 or 2 was highly significant. So based on these and other data not reviewed, In March of 2019, the U.S. Food and Drug Administration expanded the indication for MitraClip to include patients with normal mitral valves. This is secondary, not primary mitral regurgitation, who develop heart failure symptoms and moderate to severe or severe mitral regurgitation because of diminished left heart function, commonly known as secondary or functional MR, despite being treated with optimal medical therapy. Now, the next of our emerging device therapies for heart failure that I'll review is cardiac contractility modulation, delivered via the Optimizer Smart device or system. It has an implantable pulse generator with a rechargeable battery and a more than 10-year battery life. There are two RV septal leads that are used to sense and to deliver cardiac contractility modulation signals, which are applied during the absolute refractory period of the cardiac cycle and affect the biology of the selling myocardium, genes, proteins, and phosphorylation in a way that improves cardiac contractility without an increase in myocardial oxygen consumption or myocardial work, such that the efficiency of the heart as a pump is improved. And in a pivotal trial called the FIX HF5C trial, cardiac contractility modulation therapy was shown to improve exercise capacity as measured by peak oxygen consumption during cardiometabolic exercise test. It was also demonstrated to significantly improve quality of life and functional status. Here, the Minnesota Living with Heart Failure questionnaire was used as the quality of life instrument, so that a lower score is a better score. That means a better quality of life. And you can see here that the between group difference was 11 points, a very clinically meaningful improvement in quality of life score. And the proportion of patients improving their New York Heart Association functional class ranking by at least one class was highly significantly better in those patients randomized to CCM versus those randomized to the control group. Now, this study enrolled patients with ejection fractions ranging from 25 to 45%, so sort of moderately and mildly reduced LV ejection fractions. And there was a pre-specified subgroup analysis by LVEF, and you can see that these significant clinical benefits or effects were seen in both the HFrEF as well as in the HFmrEF population of patients. So based on these and other data, in March of 2019, the FDA approved the Optimizer Smart system for New York Heart Association Class 3 heart failure patients who remain symptomatic despite guideline-directed medical therapy, who are normal sinus rhythm and not indicated for CRT, and have an LVEF ranging from 25 to 45%. And then the last of these emerging device-based therapies for heart failure that I'll review with you is called Sterostimulation. It essentially is a way to electrically load the high-pressure baroreceptor in the carotid sinus. So in the setting of heart failure, these high-pressure baroreceptors are unloaded, which results in increased sympathetic activity and inhibition of parasympathetic activity. When one stimulates the carotid sinus, this electrically loads this baroreflex, producing an integrated autonomic nervous system response, which inhibits sympathetic activity and enhances parasympathetic activity, exhibiting favorable effects on the heart, on the vasculature, and on the kidney, as shown in the slide. The therapy is delivered using an implanted neurostimulation device and a surgically placed lead, stimulation lead placed over the carotid sinus to deliver barostimulation or baroreflex activation therapy. This system has been studied in a series of studies, from a small phase 1 study for proof of concept, a substantial phase 2 trial, a randomized controlled trial in phase 2, demonstrating the preliminary effectiveness, clinical effectiveness of this approach, and then the pivotal BEAT-HF trial, which has been performed under the FDA's breakthrough devices pathway. And in this pathway, the device is being studied in a two-phase protocol with an expedited phase, which led to FDA regulatory approval in 2019, and an extended phase, which is still ongoing. The expedited phase evaluated the effects of barostimulation on important biomarkers as well as symptoms and exercise capacity. And the extended phase will provide more complete data on the effects of barostimulation on morbidity and mortality outcomes. To make a long story short, in the expedited phase of this trial, barostimulation produced highly significant and clinically meaningful improvements in the 6-minute hall walk distance, in quality of life score, and in NT-proBNP. And you'll see that the magnitude of benefit on NT-proBNP, the 25% reduction in NT-proBNP, has been in other trials, such as Paradigm-HF, associated with an improvement in clinical outcomes. So based on these data, in August of 2019, the FDA approved the Barostim Neo system for patients who remain symptomatic despite treatment with guideline-directed medical therapy, are in class 2 or class 3, or in class 2 and have recently been in class 3, have an LVEF of 35% or less, an NT-proBNP of 1600 or less, and excluding patients indicated for cardiac resynchronization therapy, the patients who were studied in the VHF trial. So now my last slide is going to try to bring all of this together in an algorithm for the sequencing of device-based therapies for heart failure. You will see that the color coding on this slide indicates those device therapies which have been shown to improve both clinical outcomes and symptoms, and those device therapies which to date have only been demonstrated to improve symptoms of heart failure. And while I didn't talk about cardiac resynchronization therapy, it's old, it's been around for a long time, you know it very well, it does factor into this algorithm. So we start with the patients with symptomatic heart failure on optimally tolerated or maximally tolerated guideline-directed medical therapy, now including an SGLT2 inhibitor based on tolerability and availability. And the first question we ask is there an indication for cardiac resynchronization therapy? If the answer to that question is yes, the patient gets a CRT device with or without a primary prevention ICD as indicated. If the answer is no, the next question that you should ask is, does this patient have moderately severe or severe mitral regurgitation? If the answer to that question is yes, the patient is a candidate for transvascular edge-to-edge mitral valve repair. If not, in class 3 patients, you might then begin to consider the devices which have been shown to improve symptoms. The next question then is, what is the LVEF? If the LVEF is less than or equal to 35% in those class 3 patients, they may be candidates for barostimulation or cardiac contractility modulation to improve functional status, exercise capacity, and quality of life. And if the ejection fraction is greater than 35%, these patients may be uniquely indicated for a cardiac contractility modulation therapy. Now, I mentioned 2 other therapies on the first slide, the emerging therapy for heart failure, so I'm going to put them in the context of this algorithm, and that is the CardioMEMS heart failure system for pulmonary artery pressure guided heart failure management. It is currently approved for all LV ejection fractions in class 3 patients who have had a heart failure hospitalization in the past 12 months and may be considered in these patients based on the results of the GUIDE-HF trial presented at the ESC meeting earlier this year. This indication might be expanded to include class 2 patients as well. And then finally, the Remedy system for comorbid central sleep apnea is also approved for all LV ejection fractions and all New York Heart Association functional classes, and might be considered for the treatment of comorbid central sleep apnea in our heart failure patients. With that, I'll conclude my formal presentation, and I look forward to our later discussion. Thank you so much.
Thank you, Bill, for giving us a summary of the devices which are available today and the new technologies which are under development while we await their clinical applications for many of them. And now let me invite Dr. Sahani to tell us about some of the other highlights of this meeting.
Thank you. Thank you. Thank you, Dr. Chopra. And I've been listening to brilliant talks by both our colleagues. And now I will be discussing briefly about the AHA highlights. I will be just giving a key messages because of time. I would like to cover more trials. And let me start with the first, the Avatar trial, which is the aortic valve replacement versus conservative treatment in asymptomatic severe aortic stenosis population. We know that the background, the decision to operate an asymptomatic patient with severe aortic valve stenosis and normal LV function remains a matter of debate. And observational studies have challenged the watchful waiting in such patients, which leads to increased morbidity and mortality. So the objective of the trial was to evaluate the efficacy and safety of early surgical valve replacement in asymptomatic patients with severe aortic stenosis and normal LV function compared to the conservative treatment. They included patients more than 18 years with severe aortic stenosis, and this asymptomatic state was confirmed by exercise testing, and they excluded the critical aortic stenosis and with low ejection fraction population. And the data, the result shows that the early surgery versus conservative population, you can see here the mortality, heart failure, MI, stroke, everything was just 50% less than that of the conservative treatment. The primary endpoint was reduced and the hazard ratio is 0.46. The secondary endpoint, the secondary endpoints were the all-cause mortality and heart failure hospitalization were also significantly reduced. And when they look into the major bleeding, of course, was slightly more in surgical patient, but the MACE was not different. So in conclusion, what we found was that the largest trial in low risk asymptomatic patient with severe, mainly degenerative aortic stenosis with normal LV function, early surgery associated with low incidence of primary composite outcome in all cause death, mortality, and stroke. So intraoperative mortality was same. Then coming to the second trial is the rapid CABG trial, is a randomized study of early versus delayed coronary artery bypass surgery among patients with acute coronary syndrome treated with ticagrelor. We know the background that 10% of the patients presenting with ACIs, they go for the coronary artery bypass surgery. And major concern is perioperative bleeding. In Plato trial, we have learned that those patients who have undergone surgery within 1 day of stoppage of the ticagrelor, there was increased mortality. And based on this study, the guidelines are a little different. The AHACC says that we have to stop drug for at least 5 days before non-urgent CABG with class 1 indication, where our European Society of Cardiology guidelines says we can stop only for 3 days, but with class 2A indication. So this study was designed, there is a physician-initiated trial, randomized evaluating the safety of early surgery at 2 to 3 days after ticagrelor cessation compared to delay 5 to 7 days. The hypothesis is that early surgery is non-inferior to delayed surgery for severe or massive perioperative bleeding. So these are the characteristics. More of them are more than 60 years with a lot of risk factors, comorbidities, which we saw. And we'll look into the primary secondary bleeding outcome. There was no difference between the early surgery versus the delayed Cabg population. So what we learned from this study is that early surgery at 2 to 3 days after ticagrelor cessation was non-inferior in incurring severe or massive perioperative bleeding compared to waiting for 5 to 7 days. There was no difference in TIMI, CABG, or BARC type 4 or 5 bleeding. And the patient, those who are delayed group, had ischemic events more than the early surgery group. The early surgery group also had an additional advantage of reduced length of stay by 3 days. The other study trial, which I would like to discuss with you, is the GRAVE study, an interesting study, the coffee and real-time atrial and ventricular ectopic trial. The study is, since we have time, we can go into a little more detail. Yes, so in this study, the conventional wisdom is that the coffee leads to arrhythmias, and professional societies, they warn against caffeine consumption to avoid arrhythmias. It also known that some studies have shown that epidemiological study have shown that reduces mortality by reducing the incidence of diabetes, and perhaps coffee consumption increases physical activity, but at the same time it causes sleep disruption, which can cause worsening of the cardiovascular health and metabolic health, leading to increased mortality. So this study, the patients, those who were enrolled, were healthy volunteers, not the patient who was suffering from cardiovascular disease or arrhythmias, and those who consume coffee, willing to go without coffee for no more than 2 consecutive days, and should have a smart telephone. This was the Fitbit Flex system, and then they also did the polygenic score, and continuous ECG monitoring and continuous glucose monitoring was done using the GEO system and the CMG. So this was a randomly, the patients were daily random assigned to consume coffee versus not on any coffee. And they were, what we found the results was by using the GeoCatch system, looking at the arrhythmias, premature atrial and ventricular arrhythmia. Atrial arrhythmia, we didn't find much difference, but in the ventricular arrhythmia, we found significant reduction. And when they look into the step counts using the Fitbit system, and they found in the study that intention to treat patient, those who consume coffee were having more than 1,000 steps per day more, and for additional 1 cup of coffee, there was another 587 steps more. And looking at the sleep pattern, we found those who are consuming coffee, they were associated with 36 minutes less sleep per night. So, and when they look into the glucose monitoring, they did not find any statistically significant relation between the protocol coffee consumption and daily average glucose sleep. And then also did the CYP12, the metabolism of the coffee, looking at the patient with fast metabolizer or slow metabolizer. And then they concluded that the study has a limitation, as you said, that they included only healthy volunteers. And this concluded in the study that there was no increase in atrial arrhythmias, but there was definitely increase in PVCs, and faster caffeine metabolizers experienced heightened response. There was a clinically meaningful increase in physical activity, a clinical meaningful reduction in sleep, and slower caffeine metabolizers, they experienced a more potent effect. So there was some benefit and some negative effect of the caffeine. The other study is the Ascent Dementia Trial to assess whether aspirin 100 milligram daily affects the risk of dementia or cognitive function in adults with diabetic population. So there were more than 15,000 patients followed up for almost 7.4 years. They look into the dementia, the broad range of dementia, confusion, cognitive impairment, and the final finding from which came that there was no statistically significant difference between the aspirin and placebo in this population in reducing the dementia, although at the same time, they did not find any harmful effect also. I'll skip this because of so this was the summary of that. And the other trial also looking into the cognitive function was the, what we say, Giraffe Trial, where they look into the dabigatran versus warfarin on cognitive outcome in non-valvular atrial fibrillation to investigate the effect of dabigatran compared to warfarin. And they look into the various cognitive, extensive cognitive evaluation tests like Montreal Cognitive Assessment, mini mental test, neuropsychological battery were done and between the 2 groups of population. And these were the patients, almost 100 in each group. And score and the TTR, those who are on warfarin, was good, around 70%. And what we found that there was not much of difference between the 2 group, warfarin versus dabigatran, looking to different functions of memory, the language and attention. And the conclusion was in an older patient with atrial fibrillation or atrial flutter who did not present major cardiovascular events and were adequately treated with warfarin or dabigatran for 2 years, there was no difference in majority of the cognitive outcome. The other trial which I would like to discuss with you is the Reverse-IT trial. This is the effect of the bentrosimab on platelet inhibition and hemostasis in patients on ticagrelor with major bleeding or requiring urgent procedures. This was presented by Dr. Deepak Bhatt. And we know that the data, we know that ticagrelor is an oral P2Y2 inhibitor. Is used in acute coronary syndrome patients, high risk even in ischemic patients, trying stroke patients. As with other antiplatelet drugs, the spontaneous major bleeding and bleeding associated with urgent or emergent invasive procedures are always a concern. So antiplatelet effect of ticagrelor cannot be reversed with platelet transfusion. Therefore, a rapid acting reversal agent would be useful. And with that, there's the development of this drug, entrasimab, is a monoclonal antibody which we have to give injectable, is a recombinant human IgG monoclonal antibody fragment which binds to free ticagrelor with high affinity and specificity. Its action starts very early with onset with sustained duration of ticagrelor reversal binding. Immediate and sustained action has been seen with prolonged infusion of almost 18 grams. The effect comes within 5 minutes. And the duration we can give up to 20 to 24 hours, just like what we have been using for Praxbind for the dabigatran. The Reverse trial also showed the platelet function in both the group of population, those who needed urgent surgery or those who had bleeding, and they found a very improved reduction in the platelet activity. And these were the patients, which were the majority of the patients were surgical patients. And among the surgical patients, the cardiac surgery patients were major emergencies, CABG, although other abdominal surgery, orthopedic surgery patients were also taken. But only 8 patients were there, those who presented with bleeding, and 4 of them with intracranial bleeding and major gastrointestinal bleeding or urological bleeding. And this is a subgroup analysis, irrespective of sex, the age, young or old, and the race, and the GFR less than 60, above 60, with diabetic, without diabetes. We found the beneficial effect was sustained. So what we learned from this trial was that using the verified norm and was assessed in ticagrelor treated patients undergoing invasive procedures or with major bleeding, entrasimab, a specific reversal agent for ticagrelor, provided immediate and sustained reversal of ticagrelor's antiplatelet effect. The rates of effective hemostasis were adjudicated as good and excellent in more than 90% of patients. No drug-related serious adverse effect or allergic reaction was seen. So benefits were consistent in all pre-specified groups. So it appears to be a very promising agent for ticagrelor reversal. I think I'll stop here. Thank you very much, Dr.
Thank you, Dr. Sani. As you can see, we have so much on our plate and there's very little time to discuss all that. Yeah. But still, I think let's start.
Yes.
Dr. Kenny, maybe we can start with you. Chief HF trial. Now, basically, it was a quality of life trial. So it still doesn't translate into reduction of events or long-term prognosis. Do you think a larger trial is needed, or these results are consistent with what the other SGLT2 trials have shown us? So all the SGLT2 trials basically have one dominant effect, that is reduction in hospitalization for heart failure. The benefit in renal endpoints also have been largely similar in HFrEF, but there was a surprise in HFpEF trial of empagliflozin. So how do you see that? Do you think this is enough for us to start using this along with dapagliflozin and EMPA?
Well, certainly all these trials show the exact same thing, and there's slight variation in the p-value or the hazard ratio, but the benefit on the renal and heart failure events is really consistent. So there's absolutely no heterogeneity at all. The Chief AFF wasn't designed, it's a small, mechanistic trial that, it found what wasn't able to be seen in the larger trials, although I showed you the LASIX, that you have to look carefully at symptoms in patients who have symptoms at baseline to see that benefit. Although when we went hunting around, we saw some symptomatic benefits. So in addition to preventing heart failure events, and all the agents have the exact same finding, that, then you can get this symptomatic benefit. So all very consistent is the short answer across all drugs in all the different trials. I think that the preserved renal function thing is a bit of a fluke, that it was not designed to look at that endpoint. And EMPA-REG, the first trial, has a significant benefit. And, there are people without even heart failure, probably some of the heart failure group, it's mostly preserved. So I think that is just a little bit of a fluke and it's definitely, the drug works in preventing renal dysfunction. So there's no question there.
Based on Impulse trial, which, as you mentioned, is a relatively small trial, are you very comfortable in starting off SGLT2 inhibitors right in the beginning in acute heart failure?
It comes on the heels of the Soloist study. That also was a moderate-sized trial. It was only a little over 1,000 patients, but had a huge benefit, as I showed briefly. So I am comfortable and try to. And in fact, in the sequencing discussion, getting the SGLT2 inhibitor is important because the benefit is so quick. It's within weeks that you see reductions in hospitalization. So I think that gives added imperative, versus we also want to switch people to sacubitril valsartan and get an MRA started. And it actually helps getting an MRA started because it prevents hyperkalemia. So I think getting the SGLT2 inhibitor started earlier in heart failure of both types, preserved and reduced, is a good takeaway from all these recent studies.
Okay, so as we know, the sotagliflozin in both the trials was stopped due to loss of funding in the COVID era. The benefits there appear to be, if at all, even more than what was seen in other trials, in the sense that there was a reduction in stroke, there was a reduction in coronary events also, which wasn't seen in the other trials. Do you think that might be due to SGLT1 effect, or we don't know?
Well, it's certainly possible. I think I showed you the effect on glucose is definitely greater, and that's a distinct difference from all the other SGLT2 more selective inhibitors. It's hard to say on a secondary endpoint of stroke whether that's a real finding or not. For MI, several of the trials have found, I think it averages out to be about a 10% reduction across the different trials. So some trials have found it, others not. If you have a modest effect, the variability around the confidence interval, some trials will show a bigger benefit than others. So I'm less clear as to whether there is or is not. I think there is a modest benefit of SGLT2 inhibition on MI, but it's modest. I think it's heart failure and renal function are the bigger ones.
So would you differentiate between a heart failure admission and early start of SGLT2 inhibitors versus acute myocardial infarction with LV dysfunction? Or do we wait for trials to show the benefit? I ask this because although we saw significant benefit from Paradigm, we know that Paradise and both Paragon, they did not reach they missed their statistical significance. So many times what is seen in smaller trials, we were all very hopeful about ARNI also being positive in Paradise trial, but somehow the other in larger trials, many times the results are somewhat different.
Well, so you're saying of patients with a new low ejection fraction without a history of heart failure, is that a group that you would move to start early?
Infarction.
Yeah, I think there, of course, the indication is the ASCVD. So, it's amazing that this is literally like 2/3 of all of our patients have one of those three major indications for SGLT2 inhibition. So I think the answer is yes, but more for ASCVD than necessarily heart failure. And then as we saw, it'll reduce subsequent heart failure by 30%, even those who don't have heart failure at baseline. So it'll definitely work.
Bill, your thoughts on SGLT2 inhibitors, anything to be added? You're muted. Can't hear you, Bill. We can't hear you. We can't hear you, Bill. although you are not muted, but we can't hear you.
Can you hear me now?
Yes, very well.
Good, good. No, I was going to say, I'll just emphasize a couple of points. One, I agree with Chris. When one looks at the totality of data on SGLT2 inhibitors, these really do become part of our foundational therapy for heart failure, along with a RAS inhibitor, first line now, probably an ARNI, a beta blocker, an MRA, and an SGLT2 inhibitor. This is now the new 4-drug regimen, certainly for HFrEF, and in HFpEF and ARNI plus an SGLT2 inhibitor seem to make the most sense. And I think we'll see both enter our guidelines in the future with relatively strong indications. And it does appear to be an effect, across class, SOTA, CANA, EMPA, DAPA, all the trials may be a little nuanced or a little bit different, but again, when you look at the totality of data, I think, it's a resounding endorsement. I also would strongly advocate starting these agents in the hospital. We have done the same over the years with RAS inhibitors, beta blockers, MRAs. It's a teachable moment. Patients tend to be more adherent to medications started in the hospital, and those medications actually are more frequently started by clinicians if started in the hospital than waiting, for an outpatient visit. And then finally, Chris said something very important about the effects of these agents on symptoms, and he specifically referred to it as the effects on symptoms, which I think is really important. Not to call this quality of life, because what has come out most strongly in these trials has been a beneficial effect on the total symptom score. This is not the KCCQ overall score. This is not the total the clinical score. This is the symptom score. So I think the proper thing to say here is that SGLT2 inhibitors, and I think quite consistently across studies, improve patients' symptoms. When you roll in all the other components of the KCCQ, like social functioning and physical functioning and quality of life, the benefits seem to be a little bit, less clear. So we know that patients' symptoms improve. I think that's the fairest thing to say about that.
Yeah, I think all of us.
Sorry, you can carry on.
I think all of us have started using this in hospital itself.
Yeah.
But the issue comes, HFpEF. I think this mid-range ejection fraction was a bit of a blip in the whole scenario. Because what I have learned from these trials is, whether it is an ACE inhibitor, beta blocker, ARNI, or SGLT2 inhibitor, as you come down from 60% lower and lower, there is an incremental benefit in the effect of all these drugs. So actually speaking, if you take a true HFpEF, if you take a normal ejection fraction of say 60%, if somebody presents with a heart failure above that, we still do not have any significant disease modifying therapy apart from diuretics, and hopefully with some of the newer MRAs trials coming in, there may be something. What are your thoughts on that?
Yeah, I would agree with that statement. And it's interesting that the subgroup presentation from Emperor Preserved at AHA, set the cut point at 50, rather than 55 or 60. I do think really, LVEF is a continuous variable. It's not a dichotomous one. And we've created these, these lines at 40% or 50%. But really, looking at these, cubic spine analyses, which essentially, model this as a continuous variable, is far more important and informative than a dichotomous analysis. And I think when you do that for most therapies in heart failure, the 95% confidence interval crosses the line of unity for all of these agents, at an EF somewhere around 55 to 60%. Which means that there's less confidence that any of these agents actually improve outcomes in patients with ejection fractions above those types of cutoffs. So I think what you said is absolutely right on target when we get into this group of patients with EFs of 60%. or greater, all bets are currently off. And I'm going to say this now with one exception, brings us back to the device related approaches, which is CardioMEMS. We have demonstrated at ejection fraction cutoffs of 40, 50, higher than 50, that pulmonary artery pressure guided heart failure therapy, it's essentially diuretic therapy, does improve outcomes even in those patients with normal or high normal LV ejection fractions.
Yeah, Dr. Chopra, I have a question to ask to colleagues. The guidelines for heart failure says since the Emperor and the DAPA heart failure trials are available, they have said that DAPA or EMPA can be given 10 milligram doses, not the 25 of EMPA, 10 milligram for heart failure management. The CANA has not been studied. But do you think that this chief heart failure trial will help us to give some data in favor of CANA that this drug is also working for the management of heart failure? And some patient who's on CANA, it develops heart failure, we should not stop it. We should continue the drug as other SGLT2 inhibitor. What is your opinion? Is it the CANA is different from other two drugs for heart failure management?
I think guideline committees try to be very evidence-based. And so that figure on the one hand in the European guidelines cites basically who had a dedicated trial for each indication. And so, but the analyses, every trial shows the exact same thing in different patterns wherever it's studied. So, this is a class effect of the drugs. And the fact that there hasn't been a dedicated canagliflozin large heart failure trial is the only reason it's not listed, but it makes no sense to say, oh, it doesn't work. It prevented heart failure just as well in every other CANA trial that was done, in Credence and Canvas, et cetera. So, these drugs work and you don't need to be switching left or right. We sometimes do in the United States because the insurance got a better deal for one drug versus the other. And so we just switch to whatever the patient, insurance will cover. But, the drugs all work the same. So I don't know that one needs to get hung up on which one is listed in which guideline, but really make sure that the class is being used as broadly as it has been shown across the different trials.
So yeah, I agree with that, Chris. And from a guideline writing standpoint, I was on the 2005 ACC-AHA guideline writing committee that, for the first time deviated from this, class effect recommendation for beta blockers. But the reason for that was that there was evidence, clear evidence, that not all beta blockers were alike in the treatment of heart failure. There were pharmacological differences that, supported that, and there were clinical trials that demonstrated differences in outcomes. But I think the general approach by guideline writing committees is to presume a class effect unless proven otherwise. And here, as Chris has pointed out, all evidence for SGLT2 inhibitors points in the same direction.
Okay, so let's move on to Bill, your presentations. MitraClip. There is so much of literature now on MitraClip, and we know that COAPT trial was strongly positive as opposed to the previous one. There were obvious differences between the trials. But secondary mitral regurgitation is an ongoing process. And even if you clip the mitral valve, as the ring dilates with further dilatation of left ventricle, which will happen, what is the long-term follow-up, and are there other devices? I saw some of the devices under development in which they were slipping some kind of a ring in the coronary sinus around the LV inflow and then tightening it up. Do you think that kind of it is simpler than MitraClip? I saw a presentation of that. Do you think something like that might have a better long-term outcome?
Yeah, so this is an arena in which there has been an explosion of device development. There are many approaches under investigation to repairing or even replacing the mitral valve using a transvascular approach. And of course, given the fact that there's a lot more secondary MR than there is primary MR, this is really becoming a clinical target for the development of all of these devices. So there are transvascular approaches to, to put rings around the annulus. There's the coronary sinus approach that you mentioned. There are sort of next generation transvascular edge-to-edge approaches. And again, there are replacement approaches all under investigation. I don't think we yet know enough about these other approaches to determine which might ultimately prevail or be superior relative to other approaches. And then the other notion that I'll introduce here is that it may be that in the future we use a combination, an annular device plus a clip, to really optimize the reduction in MR to avoid the creation of too much mitral stenosis and to get a long-lasting effect. Now, in regard to the MitraClip device, we have published 3-year outcomes data from the COAPT trial, which look the same as the 2-year data. We can say that there's at least a sustained effect through 3 years, and we'll be able to ultimately present some 5-year outcomes data in the not too distant future.
What about tricuspid valve repair? There was a presentation in this AHA indicating that tricuspid valve repair, while it did help in symptomatic improvement, there wasn't any long-term benefit in it. Anything new coming up there? Because that's again a very important part of heart failure.
Yeah, so I would say, one important thing that I would note about the study presented at the AHA that you mentioned is that it was a surgical trial. And so, of course, when you tackle 2 valves rather than 1 during a surgical procedure, it prolongs the amount of time and increases sort of the complication rate and risks around that. I think the answer in the future, may be in these transvascular approaches. We don't yet have the evidence, but the tricuspid valve and tricuspid regurgitation is becoming an important target for heart failure therapies, whether that be treatment of, isolated moderately severe TR or moderately severe TR in conjunction with moderately severe mitral regurgitation as well. And again, I can only speculate at this point in time because we just don't have the evidence. But I think, I've experienced, as you and many others have in our heart failure population, the fact that significant TR creates a lot of morbidity for our patients. They often get congested livers and ascites. They have lots of refractory peripheral edema. It really impairs their functional status and their quality of life. And so I suspect that we will ultimately be able to describe a population of patients, with significant TR who will benefit from some TR reduction strategy. And I think that strategy in the future will likely be transvascular rather than surgical.
Another drug which was discussed during this meeting was about the fidelity pooled analysis of using the Figaro DKD or Fidelo DKD with Finerenone drug, the MRA. And we found the result is very promising, the reduction of cardiovascular events by 14% and prevention of progression of disease of CKD by almost 25%. So it looked like that the Finerenone may be a future drug of MRA instead of Eplerenone. Do you feel that it causes less hyperkalemia and more benefit? I don't know. What is your opinion about that?
Yeah. At this point in time, I would consider MRAs sort of tried and true. We've got almost 3 decades worth of experience with those drugs in heart failure. And I don't yet know that there's enough evidence to, recommend a fundamental shift in where we see their role in the treatment of heart failure.
And I would say there, again, the indication gets a little confusing in that SGLT2 inhibitors work in ASCVD, heart failure, and CKD prevention. And we have for spironolactone and eplerenone, the heart failure LV dysfunction group, but less so on the renal prevention. Whereas finerenone, we have renal prevention. So there's sort of two different agents that have been used and studied, so good evidence there. So I think if there's a renal indication, then the finerenone, we know what dose, how to use it, what to look for, et cetera, and less data, if at anything, in TopCat, the renal function was a little worse. So it went the opposite direction for spironolactone and heart failure on the renal endpoint as compared with finerenone. And, you noted that finerenone, it was a 30% reduction in heart failure was one of the recent publications in Circulation. So, but that's in renal patients preventing heart failure and CKD prevention.
There's a fine arts trial of finerenone and EF over 40%. We are participating in that. But that, I think the results are 2 or 3 years away still.
Yep.
Bill, how far are CCM and barostim from clinical applications, and what do you see their future, practically speaking?
Yeah, so we're seeing increasing utilization of both of these therapies in the U.S. currently. I think at least what I observe is that the uptake of CCM has been a bit more brisk than barostimulation. I think that relates in part to the fact that cardiologists who are skilled at implanting cardiac rhythm management devices like pacemakers and defibrillators can implant CCM devices because these are transvenous, leads. Whereas with barostimulation, it currently is a surgically placed lead and generally done by a vascular surgeon. So there's just a little bit more of a perceived barrier to referring patients on to barostimulation than CCM. But I would say that they're still relatively, early in their uptake in the United States, likely slowed a bit by COVID. These therapies got approved in 2019, and then COVID hit early in 2020. But their uptake is moving along. I do think that many practitioners are also waiting to get more data on these devices, in particular on their effects on morbidity and mortality.
So Dr. Krish Karan, I've got one, in this AHA, a new molecule, the oral PCSK9 inhibitor has been now developed in phase 2 trial, and they have shown a good efficacy and safety. And we know now the bempedoic acid is available to us, not in our country, but in Europe. And so for management, do you think that oral PCSK9 inhibitor will be a new drug which will be also useful for management of dyslipidemia?
Yes. The difference is the percent reduction in LDL that is to be seen. I think I just saw the reduction in PCSK9 levels, which was 90% in this initial experience. So it's a few years away, but this class has such a potent effect on lowering LDL, and the key aspect of any lipid lowering drug, at least for LDL, is the amount of LDL lowering. So if there's a pill that can do that, we're also intrigued with the once every 6 month injections, as an alternate approach, but, balancing cost is the other factor that we have to put in place. And certainly we continue to see underutilization anywhere you look in any of the things we've talked about. So trying to use the tried and true statins or ezetimibe or whatever, they all work great. So just trying to make sure people break through the misinformation on cholesterol in order to get the benefits of any of these agents.
Chris, let me ask you a question. What's the LDL target now?
As low as you can go. I think, I match it personally to a patient's risk. So general primary prevention, less than 100 in milligrams per deciliter, I guess it's 2.6 or so. For anyone with any sign of coronary disease. So imaged, positive calcium score, I'm doing more and more in the primary prevention. Then it's less than 70. Anyone who's had an MI, I do follow the European, so aim for less than 55, because there are 4 large trials that have pushed below 55 compared to around 70, all showing benefit. But then, if people get to 20 and 30, that's even better. So, but less than 55 for the higher risk, and primary prevention less than 100, and lower if people want to. So,
but American guidelines are still 70. They are.
Yeah, don't get me started on the American guidelines. They're just, they're so conservative. I don't know what they're afraid of, but they just don't adopt evidence. And they, and then the 2013 ones were just wrong, throwing out LDL. And then they've been defensive ever since, trying to backtrack, reword, we're going to use thresholds instead of a goal. And, unfortunately, they've done themselves and everyone a great disservice. So, we completed a registry, and there's just so much inertia and confusion that people don't follow, what's been shown in all the different trials because of those guidelines. So unfortunately, we've been trying to readopt LDL lower is better since 2013, and it's a slow process.
Well, I asked the question, Chris, because I was hoping you would say 55. I really, I believe in that as well, and I do believe in the lower the better in high-risk patients. But I hope we can get to 55, sort of minimally as a recommendation soon.
I think the problem is in clinical practice, as we say, lower the better, earlier the better, fine. But I personally feel together the better is better word, because achieving with high dose of statin may not be possible if a baseline LDL is more than 120. So I think adding ezetimibe in the beginning, very beginning of ASCS patient, probably this is a way to go to reach the target of less than 55. So together the better is better. So that's what I personally feel.
I like it. I've not heard that, but it certainly makes sense. And, that's what we did in the IMPROVE trial. We gave both right after an acute coronary syndrome and found it was better. So that makes perfect sense.
Yeah. So this AHA also, we had smartwatch and the Fitbit Heart study, where they have looked into the general population, taking the data from the community and look at the IHRD from the Fitbit or smartphone, and then they were given the patch, the Geo patch, 7-day smart patch for looking into this ELA, or we say the 7 days Holter recording. And they found that 33% people, those who have had the IHRD, they got atrial fibrillation of significant duration. This is that problem of atrial fibrillation, how much should be the duration is important clinically. Is it 30 seconds, is 6 minutes, it is 3 hours? That I want from you, the experts, what is the actual clinical, because in devices, when we do interrogation, we found many AF episodes of 5 seconds, 7 seconds, 8 seconds. Are they important?
Yeah, I'm happy to jump in, and I would say, this is sort of one of those totality of data, arguments. But to me, I think the AF burden is probably the right thing to consider here. Maybe not the number of individual episodes or the duration of individual episodes, although they're likely to be important as well. But based on, I think, some publications from patients who have implanted cardiac rhythm management devices, looking at AF burden and clinical outcomes, AF burden seems to be, a more important measure. So then that begs the question, where is a cutoff for AF burden? And I think, again, here, this is not a dichotomous variable. This is a continuous one. The higher one's AF burden is, the higher the likelihood of an adverse, clinical outcome. And so do I get worried about a few seconds of AF every now and then? No, but when I see these patients who have a growing burden of AF over time, you know, those patients I get more worried about, and I'm more inclined to actually try to treat their AF with rhythm rather than rate control strategies.
See, I had a patient last week who had stroke, and we did a Holter, and a Holter shows at 7 days Holter, I mean long one, shows only 7 to 8 episodes of AF of 5 to 7 seconds only, but coming every day for 7 days. But he had a stroke.
But maybe
as a case of
he might have had other longer episodes, you know, we don't know.
But
It's such a variable kind of a thing.
Maybe in future he will be able to capture. So no, this patient should be treated as a AF patient with stroke or not.
Yes.
That is my worry. I'm not sure. But
well, you know, the one takeaway I've had is that the more you look, the more you find. And so if you see that much on a 7-day, if you had an implanted thing, you'd see all kinds of stuff over 6 months.
Oh, yeah,
but, you know, so knowing that, to see whatever you say, it's almost like, you know, if people say, oh, I only eat so much, then you know that they eat a bit more than that, or what have you. But, you know, the other thing is the anticoagulants are very safe, the NOACs. And so, you know, the Averroes trial is my favorite one. It compared aspirin and 85% low dose aspirin to apixaban. The bleeding was identical. So if people somehow say, oh, I'll take an aspirin, even though that doesn't really help, you know, the safety of taking an anticoagulant was shown there, so that, you know, there's very little downside. If you've got hints of AFib, and certainly if the poor person's had a stroke, you know, that's an obvious they need anticoagulation. But to try and encourage more use on the anticoagulant if there are hints of this. And then, you know, doing the longer term monitoring, I think, is something that's easier to do now, and then can be very enlightening that then it's a definitive answer if you put in an implanted device.
In the last few minutes, let's talk about two things. Chris, you mentioned that rapid CABG might be your favorite trial. I saw your statement. Does it, I mean, this is encouraging because it really does change the practice. We know that waiting for a longer period in these people can result in more episodes of ischemia and so on and so forth. So that was good. What about Avatar, which Dr. Sani presented? Early surgery in asymptomatic patients, and all these patients had exercise testing done, as opposed to a previous smaller trial in which exercise testing was not done. So how do you see that? And do you think that that is something that we would like to follow? Because till now the teaching has been that even if aortic stenosis is significant, but there are no symptoms, watch those people unless it really becomes critical. How do you see that? Chris, and then Bill.
Well, you know, the good news of these trials, I think, is that the safety of either TAVR, or in this case, surgical, is getting better and better, so that the downside of surgery is less, and then it can, you know, lead to benefits. So I think this was a very eye-opening study to really call into question the symptoms as a driver. So I think there it's obviously a discussion. To have surgical aortic valve replacement is a big deal. So you can't just say, oh yeah, get a valve replacement. But that discussion can now start earlier, I would say, as the echo gets more and more significant. Then you know, and certainly in mitral regurgitation, you know, mitral valve repair, we do that earlier and earlier because outcomes are better. So the concept of not letting the heart deteriorate and then going in and fixing it, but catching it sort of early enough before you have complications, I think that seems to be a strategy that's emerged because of all of our interventional and surgical approaches are getting better and better.
Bill?
Yeah, I would just comment that, you know, I think symptoms, you know, generally represent only a crude measure of disease severity and progression. And I think within the structural heart arena, we really have come to appreciate over the past decade or two, the importance of treating the underlying disease, the underlying pathophysiology, particularly of valvular heart disease. So I think this is a very important study. It sort of is the progression from, studying severe and then moderate and then mild and now asymptomatic. And I think the trial was done in a very robust fashion. As you mentioned, it did include exercise tests as well, because one of the criticism of earlier studies was that maybe patients didn't complain at rest, but had exercise-related symptoms that weren't well documented. This trial, Avatar, went on to look at that as well. I think it's a very good study, and I think it does support early intervention in these patients.
And it may actually be a guide to using earlier transcatheter repairs, because as these things become, in your country, of course, they're very common. It's catching up here also. But as the cost comes down and technique gets refined, maybe people will be more inclined to use this.
Absolutely. It's, watching a patient walk out of the hospital the next day, rather than having to follow them in the surgical intensive care unit and then out on the ward for a few days and send them home with, sort of months of healing and rehabilitation after their surgery is really quite appealing, right? To prefer TAVR over surgical approaches for this disease.
Okay, so final 2 minutes.
Chopra, I want to ask you, Dr. Chopra, looking at the Crave study, an interesting study on coffee, and we know in our country that is not that popular. We take more tea, but on average, 4 to 5.
We take plenty of coffee also. See,
but the tea consumption is very high, and that to patients those who are already suffering with some arrhythmias, and this study was done on healthy volunteers. Okay, still they have shown increased PVCs and other effect on sleep and exercise, good points and bad points, and probably it nullifies the benefit of coffee. But what about the tea? I think you should start a study in India on tea consumption, which is on average 4 to 5 cups per day.
Yeah, but the thing is, what is applicable for healthy volunteers may not be applicable for a person with a diseased ventricle. So I think I would be a little bit careful about straight away jumping into that. What do you say?
I don't know, but that's what I say, that the result would have been different, healthy versus a person who is already suffering from arrhythmia. I'm sure it will aggravate more in those patients, those who are suffering. So it looks like a cup of coffee is good. But on average, I don't know in US what is the number of cup of coffees an average person consumes.
They always have a mug in their hand.
Yeah, it's a good question based on the N of 2 study here with Chris and I guess I would say it's pretty high, but I like your idea of doing a tea study. It would have to be caffeinated tea, of course. And, then we could figure out if this was a caffeine effect or a coffee effect. But I tell you, the study presented at AHA, creates a dilemma for me, which is, do I want to exercise more or sleep more? Now I've got to make a choice.
Yeah.
Okay. Finally, something which has been with us for a long, long time, and we are still struggling with it: stem cell therapy. There was a paper presented. It was probably one of the larger studies, which indicated that the primary endpoint was hospitalization for heart failure. That was no different, but mortality seemed to be less. What is happening with stem cell therapy, Chris and Bill?
The DREAM heart failure trial, you're mentioning about that?
I forgot the name.
I have to say, I don't know much about it. It's certainly not panned out over the last 20 years. So it's a work in progress still, is all I've seen. But
yeah, I would agree with Chris. I started saying in lectures around 1995 or so that stem cell therapies were just around the corner in heart failure. And now, so many years later, they're still just around the corner.
It is still around the corner.
Yeah.
Yeah. I think that this is the DREAM heart failure trial. They used the allogenic precursor of mesenchymal cell, and they did not find much of reduction in events, but some reduction of hospitalization for heart failure.
No. There was no reduction in hospitalization. There was some reduction in mortality. which was kind of peculiar. So I think that brings us to the end of our allotted time. And I would really like to thank both our guest speakers, Bill and Chris, and Dr. Sani, of course. It has been a wonderful learning experience, and we have enjoyed interacting with you. And I'm sure our audience also did. Thank you all. And finally, I'd like to thank Mankind Pharma for supporting this program. Over to these.
Thank you. Thank you so much, sir. That was really brilliant, wonderful, and thanks for such a kind of the learning forum to be created. And I'm sure that all our attending clinicians in the audience got immensely benefited out of this this cutting edge science which is being brought over here. Thank you so much, Professor Christopher Cannon, Professor William Abraham, Professor Dr. P.K. Chopra, sir, Professor Dr. J.P. Sani, sir. Thank you so much. Thanks for joining this meeting. Thank you. Stay safe. Good night. Right. Thank you very much.
Thank you all.
See you at ACC.
Good night.
Bye-bye.
Thank you.
Bye. Good night.
Bye.